Intestine, Part 2. Inflammatory bowel disease. The term inflammatory bowel disease is usually used to denote ulcerative colitis and Crohn's disease. However, bowel inflammation can be caused by other diseases as schistosomal colitis, amoebic colitis, typhoid enteritis, and ileocecal tuberculosis. Ulcerative colitis, definition, inflammatory disease of the colon or colitis characterized by ulcerations. Etiology, unknown etiology, but immunological, genetic, and environmental factors are possible causes. Pathology, site, beginning at the dentate line of the anal canal and extending proximally, may involve rectum alone, proctitis, up to the whole colon, and rectum affection, pancolitis. Macroscopic picture, extension is continuous with no skept areas of normal bowel. Mucosal affection is variable from granularity to extensive ulceration. Microscopic picture, only the mucosa and submucosa are involved, unlike Crohn's. The characteristic histological feature is crypt abscess formation in the depth of the glandular tubules with surrounding inflammation. The abscesses fuse to form ulcers. Pseudopolyps are likely to be found. Complications, intestinal and extraintestinal. Intestinal toxic megacolon from 3 to 5% of cases, and it can be fatal. Hemorrhage, colon cancer, the risk is higher in patients with pancolitis for more than 10 years. Carcinoma on top of ulcerative colitis is often multicentric. Extraintestinal complications include uveitis, cholangitis, arthritis, liver cirrhosis, and skin lesions as pyodemia gangrenosum and erythema nodosum. Clinical picture, type of the patient, more common in females, and the commonest age is from 30 to 40 years. The complaint, watery diarrhea mixed with blood, pus, mucus, and tenesmus, pain, fever, weight loss, and dehydration occurring to variable degrees. The course, characterized by occurrence of remissions and relapses. Clinical picture of the complications, as toxic mesocolon is a very serious complication. It's a very severe diarrhea with passage of blood, mucus, and pus in the stools. The patient is very toxic with severe pyrexia from 39 to 39.5 degrees Celsius. Abdominal examination shows severe abdominal distension due to marked colonic atony. If not treated urgently, a fatal outcome can occur. Investigations, radiological, instrumental, and laboratory. Laboratory, CBC, anemia and leukocytosis in acute cases, hypoproteinemia and hypokalemia in severe cases. Instrumental, colonoscopy and biopsy, showing mucosal abnormalities, detecting upper extent of the disease, and it's contraindicated in toxic megacolon. Radiological, barium enema, revealing mucosal irregularity and ulcers, colonic shortening, and loss of hostrations leading to something called pipe stem appearance in long-standing diseases. Contraindicated in presence of toxic megacolon. Aminosalicylic acid is a major drug in the treatment of ulcerative colitis, so all patients with ulcerative colitis should take it. Treatment option depends on the severity of the disease. The disease is severe if there is equal to or more than 6 bloody motions per day, with fever more than 37.5 degrees Celsius. Mild disease, moderate to severe, and resistant cases. Mild disease, we give oral 5-ASA, aminosalicylic acid, or by enema. Moderate to severe, oral 5-aminosalicylic acid or enema, with prednisone orally or enema, or IV hydrocortisone. For resistant cases, immunosuppressive drugs as cyclosporin, adaciprine, or mycophenolate mofetil, biological agents, and fleximab. Nutritional therapy, in majority of patients, well-balanced healthy diet, avoid only foods which are poorly tolerated by experience. In small intestine strictures, avoid raw fruits and vegetables because it precipitates intestinal obstruction. In cases of combined proctitis and constipation, increase dietary fibers. Surgical treatment indications, failure of medical management to control the disease, leading to chronic ill health with persistent diarrhea, anemia, and malnutrition. Development of complications as toxic megacolon with perforation, urgent surgery, or colon cancer. Long-standing pancolitis where biopsy shows dysplasia. And finally, stricture formation. Surgical options, panproctolectomy, the standard treatment, excision of the whole colon and rectum with permanent ileostomy. Colectomy, the colon is excised, but the rectum may be spared and ileorectal anastomosis is performed. Lifelong observation of the rectum is needed for the fear of development of rectal carcinoma. Proctocolectomy, with distal rectal mucosectomy, excision of the colon and upper half of the rectum is performed. The mucosa of the lower part of the rectum, the site of the disease, is cored out, leaving the muscular wall. An ileal pouch is fashioned to act as reservoir and anastomose to the anal canal within the preserved rectal muscles. Not suitable in an emergency setting. Despite the risks, 95% of patients are satisfied with the procedure and have good quality of life after IPAA. Crohn's disease or regional ileitis. Definition: idiopathic chronic transmural granulomatous inflammation which can involve any area in the GIT. Etiology: unknown but may be hereditary or disturbances in the immune system. Pathology: site: it can affect any part of the GIT from the mouth to the anal canal. The commonest is the distal ileum. The old name is regional ileitis. The next common site is the colon, followed by the anal canal. Macroscopic picture: characterized by granuloma formation. The affected segment is thickened. The mesentery is also thickened and containing enlarged lymph nodes, characterized by scap lesions, healthy gut between the affected parts. In long-standing cases, multiple fissures occur with edematous mucosa in between, leading to something called cobblestone appearance. Microscopic picture: inflammation involves the whole thickness from mucosa to serosa, transmural. There is non-caseating granulomatous infiltration of the lymphatics of the submucosa with the presence of giant cells. In late cases, fibrosis extends to and obliterates the submucosa. Complications: intestinal and extraintestinal. Intestinal: abscess and fistula to another loop, bladder, vagina, or to the skin. Stricture of the small intestine leading to intestinal obstruction. Perianal abscess, anal fistula, and fissure. Malabsorption in extensive diseases, or those who had extensive intestinal resection. Extraintestinal complications: inflammatory, ocular, joint, skin, and hepatobiliary lesions. They are similar to those of ulcerative colitis. Clinical picture: type of the patient: males equal to females. The peak age of onset is in the 2nd to 4th decades. Symptoms: diarrhea, abdominal pain, weakness, anorectal disease, weight loss, and in long-standing cases, they may present with intestinal obstruction. Barium meal follow-through is done for suspected small intestine disease, while a barium enema is indicated for suspected colon disease. Signs: we have general anemia and malnutrition, local, a mass in the right iliac fossa. Investigations: radiological, barium meal and follow-through, showing segmental areas of structure separated by scap areas of free bowel, cobblestone appearance of mucosa due to longitudinal fissures. It may also show internal or external fistulae. A narrowed terminal ileum segment is called string sign of Cantor. Instrumental biopsy and colonoscopy of large bowel lesions proves the diagnosis. Biopsy of suspected anal fissures and fistulae. Treatment: medical treatment. The aim is to induce and then maintain remission. For active small intestine involvement, prednisone, whether IV or orally, according to the severity, and reducing the dose once improvement occur. For resistant cases, immunosuppressive drugs. For active colitis in mild cases, sulfasalazine. In moderate to severe, prednisone, and in resistant cases, immunosuppressive drugs. Removal of long intestinal segments is avoided because it leads to malabsorption. Strictureplasty doesn't treat Crohn's colitis, as there is a 7% risk of malignancy over 20 years, according to the Washington Manual of Surgery. Surgery, reserved for complications but becomes necessary in most cases. Indications: failure of medical treatment, complications as acute systemic sepsis, perforation, uncontrolled hemorrhage, failure to thrive and malnutrition, dysplasia, and malignancy. Operations: limited resection of the affected area, as the patient may be subjected to further resections in the future. Strictureplasty, folliculized strictures, incise the stricture longitudinally and close it transversely to widen the lumen. Bilharzial colitis, etiology: caused by infestation with Schistosoma mannsoni and by Schistosoma hematobium, which is less commonly. Pathology: site, usually at the sigmoid colon and rectum. Chronic inflammatory cells surround the deposited ova, leading to bilharzial granulomas. The disease may produce ulcers, polyps, or bilharzial pericolic mass. The condition is not precancerous at all and doesn't produce strictures. Complications: partial rectal prolapse, prolapse and strangulation of a polyp, hypoproteinemia due to chronic protein loss, and anemia due to chronic blood loss. Clinical picture: type of the patient. The disease often affects young adult males in rural areas in Egypt. Symptoms: diarrhea, tenesmus, weakness, colics, passage of mucus and blood in stools, dyspepsia. Signs: general, pallor and clubbing of fingers with ulceration of polyps. Local: the sigmoid colon is palpably thickened and tender. Hard nodular mass filled in the left iliac fossa. In the diffuse form, the mass is mobile or fixed and hard, simulating cancer, but no intestinal obstruction occurs. And the DRE commonly detects multiple polyps. Investigations: lab, stool analysis showing blood, pus, and probably viable bilharzial ova. Urine analysis: Revere-associated urinary infestation. CBC showing anemia. Liver function tests reveal hypoalbuminemia. Instrumental: sigmoidoscopy showing mucosal changes. Examination of fresh biopsy or ulcer scrapings showing ova. Radiological: barium enema showing multiple rounded filling defects of the polyps. The sigmoid colon may be pulled to the right iliac fossa. Treatment: anti-bilharzial drugs, oxamectin and praziquantel. Polyps: polypectomy by fibro-optic colonoscopy. Surgical complications of typhoid and paratyphoid. Intestinal hemorrhage and perforation of a typhoid ulcer. Due to ulceration of the affected Peyer's patches in the lower ileum, the ulcer is parallel to the long axis of the gut, occurs 2 to 3 weeks after the onset of the disease, presenting as dark blood per rectum, which may be bright red if profuse. For the perforation of the ulcer, it may occur around the 3rd week, leading to peritonitis. Pus is evacuated because it needs urgent exploration under cover of chloramphenicol. The perforation is repaired, or the affected ileal segment is resected. Biliary: acute non-calcular cholecystitis and chronic cholecystitis in the carrier state. Vascular: deviation of the lower limbs due to prolonged recumbency. Intestinal tuberculosis: we have ulcerative tuberculosis and hyperplastic ileocecal tuberculosis. Ulcerative tuberculosis, according to the etiology, secondary to pulmonary TB or swallowing of the TB bacilli. Pathology: presents as multiple ulcers in the terminal ileum. The long axis of TB ulcer lies transversely, while hyperplastic ileocecal tuberculosis. For the etiology, primary infection due to ingestion of TB bacilli, bovine or human type, by patients with high resistance. For pathology, site, ileocecal region, commonest. Intestinal wall is much thickened and lumen is narrow. Regional lymph nodes early are involved and may caseate. Clinical picture of the ulcerative tuberculosis: diarrhea, abdominal pain, weight loss with complications, stricture, intestinal obstruction, and perforation, which is rare. For hyperplastic ileocecal tuberculosis, the clinical picture is abdominal pain, intermittent diarrhea, and mass in the right iliac fossa in ill healthy patient. For the complications, abscess and fistula are rare, while intestinal obstruction if left untreated. Investigations for the ulcerative tuberculosis: barium meal follow-through, positive steriline sign, non-visualization of the terminal ileum and cecum. Treatment in early cases: anti-TB drugs and intestinal stricture, surgical excision. For the hyperplastic ileocecal tuberculosis, barium meal and follow-through showing narrowing of the lumen of the elevated cecum up to subhepatic. Treatment: medical by anti-TB chemotherapy. Surgical: right hemicolectomy with removal of the diseased ileum in obstruction and, if cannot exclude malignancy. Intestinal ischemia divided into acute and chronic. Acute intestinal ischemia is a very serious surgical emergency which is highly fatal, commonly affecting large intestinal segment but may be focal and affects small segment. Acute intestinal ischemia definition: occlusion of one or more of the mesenteric vessels, usually the superior mesenteric artery or vein. Etiology: acute mesenteric vascular occlusion, mesenteric arterial embolism or thrombosis, or mesenteric venous thrombosis. Mesenteric venous thrombosis idiopathic or due to pulmonary hypertension, intra-abdominal sepsis, hypercoagulable states, intake of OCPs. Mesenteric arterial thrombosis due to mesenteric atherosclerosis with history of intestinal angina. The extent of ischemia is more than that with embolism, as the block is at the mouth of the superior mesenteric artery, sparing none of its branches. Mesenteric arterial embolism: the source may be atrial fibrillation with left atrial clot, mural thrombus after myocardial infarction affecting the left ventricle. The embolus usually lodged within few centimeters of the mouth of the superior mesenteric artery, sparing the middle colic and few of the upper jejunal branches. So the difference between embolism and thrombosis of the mesenteric artery, that there is sparing in the embolism for the middle colic or few of the upper jejunal branches, while in the thrombosis there is no sparing for the branches. Non-occlusive intestinal ischemia with low cardiac output states as arrhythmias and major sepsis, splanchnic vasoconstriction leads to intestinal ischemia, leads to gangrene. Differential diagnosis: acute pancreatitis and intestinal strangulation. For the acute pancreatitis, the common features are severe pain, vomiting, minimal local signs in the early phase, and shock. The distinction is important to decide the management. acute pancreatitis, conservative management, while acute mesenteric vascular occlusion requires urgent surgery. Pathology: damage occurs from ischemia and reperfusion. Ischemic damage within 3 hours of complete vascular block, mucosa sloughs, ulcerates, bleeds into the lumen. Bacteria get access to the bloodstream through the damaged mucosal barrier, leading to something called bacterial translocation. Within few hours, the whole thickness of the intestinal wall is affected, exuding serosanghinous fluid in the peritoneum. The patient may lose great amounts of blood. The intestine becomes gangrenous, perforates, leading to peritonitis. The gangrenous bowel loses peristalsis, acting as an obstruction. The proximal intestine becomes distended with fluid and gas, where peritonitis develops, leading to paralytic ileus, leading to more distension. Reperfusion damage, the return of blood flow spontaneously or by surgery, leads to release of oxygen radicals, which damages the cell membrane. Clinical picture, symptoms and signs. Symptoms: severe acute abdominal pain, this is the main symptom, not responding to narcotics or nasogastric aspiration, vomiting with variable degrees, and bleeding per rectum. Signs: early and late. Early, little physical signs not matching the severity of pain. Later, blood loss leading to hypovolemia and perforation leading to peritonitis, so patient presenting with generally shock and local abdominal tenderness, rigidity, and distension. Investigations: lab, CBC, marked leukocytosis, elevated hematocrit value except in massive blood loss. Serum amylase elevated in half of the patients, but not as high as in acute pancreatitis. Radiologically, plain X-ray of the abdomen showing air fluid levels in the proximal intestine, lately intestinal necrosis, showing as intramural gas or gas in the portal venous system. Arteriography, its value is controversial and may delay surgical intervention. If there are findings diagnostic of superior mesenteric artery embolism, preoperative infusion of papaverine directly in the artery improves intestinal viability. There is no specific or sensitive test to prove the diagnosis. The most useful aid is to put the condition in mind, particularly in the atherosclerotic patients or patients with cardiac arrhythmia. Treatment: urgent surgery is the key to survival. Preoperative measures: restoration of blood volume by blood and crystalloid infusion, parenteral antibiotics, nasogastric decompression by Ryle's tube. Laparotomy is done to resect gangrenous intestine, peritonitis with friable tissues, doubtful viability of the remaining intestine, or in patients with bad general condition. If those three terms are present, stoma and ileostomy bag, then bowel anastomosis is postponed until general and local conditions improve. But if they are absent, primary anastomosis done, and second look operation after 24 hours is advised by some surgeons to check the viability. Restore arterial blood flow in cases with reversible ischemia, in MAE, embolism, embolectomy, and in thrombosis and arterectomy or bypass surgery. In mesenteric venous thrombosis, diagnosed at operation by presence of edema of the mesentery and extrusion of the clots from the mesenteric veins when they are cut. Treatment: resected gangrenous intestine. Post-operative management: the patient is given post-operative heparin, discharged under oral anticoagulants for at least 3 months to prevent recurrence. Prognosis: mortality rate of mesenteric venous thrombosis 30%, arterial occlusion 45%, embolism better than thrombosis. Resection more than 70% of small intestine leads to something called short bowel syndrome. Short bowel syndrome, main feature, malabsorption. Many months are needed to accommodate by increasing absorptive surface. Patients are fed initially total parenteral nutrition for a few months. Later, gradual oral intake is introduced, reducing the amount of parenteral feeding until the patient can depend totally on normal oral feeding. Chronic intestinal ischemia, definition: narrowing of the superior mesenteric artery and sometimes the celiac artery. Etiology: atherosclerosis, the main cause. The enthema of the superior mesenteric artery is thickened in its mouth, leading to narrowing. Compression of the celiac artery by the median arcuate ligament of the diaphragm, which is a rare cause. Clinical picture: type of the patient, elderly patient who are likely to have atherosclerosis. Symptoms: abdominal angina, this is the main symptom. Postprandial pain, starting 15 to 30 minutes after a meal and lasting for about an hour. The patient is usually afraid to eat, because of which he loses weight. Signs: an upper abdominal bruit in the majority of patients. Clinical search to find atherosclerotic narrowing of other arteries. Investigations: aortography, diagnostic, particularly its lateral view, which shows narrowing of the origin of the artery and presence of collateral circulation. CT angiography, non-invasive, providing 3D image. Ultrasound and upper GI endoscopy exclude other causes of chronic abdominal pain. Treatment: atherosclerosis, surgically treated either by endarterectomy, coring out the second enthema, or by inserting bypass dacron graft from the aorta to the superior mesenteric artery beyond the narrowing. Median arcuate ligament compression, division of the ligament. Ischemic colitis, etiology, a drop of blood pressure for any reason, this is the usual factor, or surgery on the abdominal aorta if the inferior mesenteric artery is sacrificed. Clinical picture, type of the patient, 15 to 70 years old, with chronic vascular disease of the mesenteric vessels, symptoms, acute abdominal pain and passage of blood per rectum. Site, splenic flexure, most commonly affected. Investigations, plain X-ray, showing some prints due to edematous mucosa outlined by bowel gas. Consequences, complete resolution, gangrene, perforation and peritonitis, and finally stricture. Treatment supportive by IV fluids, analgesics and antibiotics. Surgery, rare for gangrene or stricture formation.